Welcome to the session. Thank you for joining. And I just want to extend a special thank you to our speakers and also our colleagues who were part of this Delphi study on which the topic is of today, mental health and substance use disorders in prisons in Africa. The Global Mental Health Peer Network is hosting this, and we're very excited to really have this critical discussion as a partner in this collaborative initiative with the Africa Mental Health and Justice Network. Helen will maybe talk a bit more about that if you're interested in how you can join. This is a special interest group that was established from this piece of work to really advocate for the prioritization of mental health and well-being in prisons in Africa. As you know, the justice system does not start or end in prisons. The system in its entirety really extend to the police and may also involve forensic or psychiatric facilities where people are incarcerated or detained. What's very important around what we focus on is that mental health and well-being is a human right. It's a right to every individual, and it doesn't matter where you are. It's a right to anyone who enters the justice system. So everyone has a right to dignity and, of course, a right to health and health care. So today we will hear from our speakers, who I will briefly introduce and do a round to introduce themselves. And we will have a discussion around the situations in the context of the justice system. What are the gaps? What is needed to protect mental health of those who enter the justice system, and also how it is linked to human rights. So I just want to share my screen here. Just to introduce. So this is who we have as presenters today and panelists. Dr. Helen Jack, Dr. Adegboyega Ogunwale, Professor Dainius Puras, and Sandra Ferreira. So I'm going to do a round for each in this sequence. If you can just briefly introduce yourselves, your backgrounds, and kind of what you're involved in at the moment. And just before we go there, I just want to show this work has been published in the Lancet Psychiatry, and if you want to access the paper, you can scan this QR code, and Helen will also put the link for you in the chat, which you can also access in that way. So I'm going to hand over for introductions. Helen, over to you.
Hi, everyone, and Charlene, thank you so much for hosting. I'm Helen Jack. I'm a primary care physician and researcher based at University of Washington.
Thank you. Ade.
Hi, everyone. Thanks, Charlene, for inviting us to this conference. My name is Adegboyega Ogunwale. I'm a psychiatrist from Nigeria, and I'm a forensic psychiatrist. I do some ad hoc work in prisons, and currently I'm a PhD student at the Institute of Psychiatry, Psychology, and Neurosciences, King's College, London, where my doctoral research is focused on the impact of mental disorders in Nigerian prison population. I'm glad to be here.
Thank you so much, Ade. Dainius, over to you.
Hello, I'm Dainius Puras. I'm professor in Vilnius University, Lithuania. My field is public mental health and child adolescent psychiatry. So I have been working many years mainly in my region, which is, let's say, Central Eastern Europe. But then for 6 years, from 2014 to 2020, I was United Nations Special Rapporteur on the right to physical and mental health, and my priority was mental health and human rights, and I did some reports on mental health, but also one report on deprivation of liberty and right to health. So now, after already five years, I do not have a hat, but I'm happy also to serve as a former special rapporteur with my experience. This is a little bit easier to be former special rapporteur,
Indeed.
and I will be happy to contribute also today with my insights. Thank you.
Thank you so much, Dainius. Over to you, Sandra.
Hi, everyone. My name's Sandra Ferreira. I'm based in Johannesburg, South Africa. I'm an expert by experience. I have a professional history in education with an honours degree in educational management, and obviously very happy to be part of the conversation today. Thanks, Charlene.
Thank you, Sandra. I think did you forget to say that you're part of the...
I did. Sorry, I'm the global network manager for the GMHPN. Sorry, missed that one.
Thank you so much. Okay, so I'm going to go straight to Helen, who will give you kind of more background on this piece of work and present kind of the methodology and the results. And yes, over to you, Helen.
Excellent. So what I am going to do, I hope everyone can see my screen, is tell you a little bit about the research that is sort of laying the foundation for the conversation we're going to have today. So much of my research has been with collaborators in Zimbabwe, where I've been working since 2013. And many years ago, we did a study where we interviewed people around Zimbabwe who were key stakeholders within leaders in the Zimbabwean mental health system. And we did not ask them about prisons because prisons were not a big part of the conversation about mental health globally. And we were surprised when many of them started talking about how a lot of the country's mental health services are delivered in the prison system and how many psychiatrists work in the prison system. And the prison system really is part of the mental health system in Zimbabwe. And that was interesting to both myself and to my colleagues because we really hadn't seen a lot written on the prison system. And when we started looking around at global guidelines, there was not a lot on incarceration and mental health. And so that prompted us to do a systematic review. So to try to identify all of the existing academic work that has been done on mental health and substance use in people who are detained within prisons and other settings of detention in Africa. So coming out of this systematic review, we found that there had been 80 studies ever done on prison mental health and substance use in Africa. 2/3 of them were prevalence studies. They documented, perhaps unsurprisingly, a very high prevalence of mental health and substance use conditions in prisons. And though it was really variable across settings. There was a small number of studies that also documented poor prison conditions and issues around implementation of prison mental health policies. These were primarily descriptive qualitative studies. And unfortunately, despite this very large burden of mental health conditions and substance use disorders, very, very few studies have been done looking at what we should do about this. In fact, there had only been 3 intervention studies ever published, 2 looking at psychological therapies in carceral settings, and 1 looking at a long-acting antipsychotic in carceral settings in Africa. And in addition to looking at the academic work, we looked at both UN and WHO guidelines on prison health and on mental health. And while it was not uncommon that prison mental health was talked about in UN guidelines on prisons, prisons were almost never talked about in WHO guidance, things like MHGAP, guidelines on treatment of mental health conditions. Prisons were not often mentioned. We actually reran the search for this systematic review last year and found that while the number of prevalence studies has gone up, we are continuing to document that prevalence is very high in these settings. There continue to be no additional intervention studies looking at what we should do about it. And so in that context, that was why we decided that, like, faced with this high burden of disease and very little international attention, where do we even start? And where do we start should be informed by people with the greatest expertise in this area, the people who have lived experience working or being incarcerated in these facilities. And so we decided to use the Delphi method to develop research and practice priorities related to mental health and substance use among people who are incarcerated in sub-Saharan Africa. The Delphi method is a strategy for developing group or expert consensus through a series of iterative surveys on a specific question that cannot be answered with existing evidence. So it really is a way to bring people together to asynchronously develop consensus on something that just can't be measured, like priorities for prison health. This work was truly led by an incredible advisory board, many of whom are here today, of people from around the continent who are lawyers, doctors, activists, people with expertise through lived experience, truly an incredible group of people, led this work. And based on their recommendations, as well as looking to the authors of people who had written studies in this field or who were doing other work in this field, we recruited experts from around sub-Saharan Africa. And we asked our initial participants to recommend additional people who we should include so we could try to really comprehensively get a lot of voices in this Delphi panel to establish these priorities. And so how does a Delphi actually work? Well, we got this big list of experts and we sent them an open-ended question via an online survey. We asked them to, and you'll see this written on the slide, we ask you to state issues that you think are priority challenges, specific barriers that, if removed, would improve health outcomes for incarcerated people with or at risk for mental health and or substance use disorders in sub-Saharan Africa. We then got a ton of free text feedback back, and we clumped that into a list of priorities, and we sent those priorities back out to the same group, and we asked them to rate them in order of importance on a 1 to 7 Likert scale, with 1 being not very important and 7 being really important. We then got that data and we rank ordered the priorities in order of the one that people had rated the highest, the one that people had rated the lowest, and we sent that list of priorities back out to everybody. We cut the bottom quarter and we presented the summary statistics for how the priorities had been rated in the prior round, because the theory behind Delphi's is that if you see that other people thought that something was important, you might also think that it is important, and that is how these surveys help to build consensus. So we did that 2 more times, cutting the bottom 25% each time, and we had set an a priori threshold for determining what does it mean to have consensus that this is a priority, and that's shown here. We worked really hard to increase access to participation in the Delphi. We offered it in English we're participating in this from, and we did a lot of our outreach via WhatsApp, not necessarily via email, so that we could reach people who are not using email regularly. So what did we find? We had 97 participants participate in the first round of the Delphi, which was 64% of those we reached out to, which is pretty good for an online survey. The participants lived in 24 countries. 47% of them had lived experience of a mental health condition, substance use disorder, incarceration, or being a caregiver of someone with one of those things. They worked in a wide variety of professional roles. They were researchers, doctors, policymakers, across the rounds. And we had said at the beginning that we would stop after 4 rounds. So we're able to retain people across the rounds. And so in each round, we would cut some priorities and we would slightly change the language of the priorities if we got feedback from the participants that they thought something needed to be reworded. And we did not, in fact, reach our a priori definition of consensus. And so we decided at the end of the fourth round, which is when we said we would stop, that we cut the bottom quarter, and we did several sensitivity analyses and stability analyses to look at if we had looked at this data differently, would we have come up with the same priorities? And I think coming out of the fourth round, despite not meeting our a priori definition of consensus, we felt pretty good that the 38 priorities that we had come up with were a really good starting place for a conversation on what are priorities for prison, mental health, and substance use. And so we took the 38 priority challenges and we grouped them into 10 categories to make them a little bit easier to digest. The full priorities are listed in the paper that all of you can access, which is recently published in Lancet Psychiatry. And I'm just going to talk you through 3 of these categories just to give you a sense of the types of priorities that we were seeing. So one of the major issues that came up was behavioral health care cascades during incarceration. A care cascade is really steps in delivering care. And one of the things that was very clear is that implementation of basic steps in the care cascade is a high priority. So that is screening and diagnosis upon entry into prison, which was one of the top ranked priorities. Access to medications for those who are screen positive and receive a diagnosis, development of management guidelines that are specific to prisons because they are different contexts than community-based settings, adaptation of psychological interventions from community-based setting to be fitting for the prison setting. And you'll see on this slide, the next to each priority, I've listed the quartile in which it fell in the final 38. So these were very high-ranked priorities. A very clear priority was also the healthcare workforce, both specialists and generalists. We need more of them to be able to effectively deliver services in these settings. And we need to be widening the tent, bringing people who may not be traditional healthcare workers into the conversation about how to provide care in this setting. And finally, prison conditions are a mental health problem, right? If prisons are overcrowded, if there is poor sanitation, if there is not enough food, if there are not spaces where people feel safe, that is a mental health problem. And we cannot talk about participating in psychological therapy and really being able to engage with that unless we are willing to grapple with what prison conditions look like. And I think that was another clear priority coming out of the Delphi. So I think overall themes looking across all of the priorities is it is time to look beyond measuring the prevalence. We know that there is a problem, that we really need to focus on implementation. What does it take to start putting things into practice? And that is coming from the research side, that is coming, I think, more importantly from the practice side. How do we work to bring funding and implementation support to start to make care delivery happen? And that needs to start with developing basic infrastructure. There was no emphasis on additional descriptive studies. I think what was also very clear was the enthusiasm of the people who participated in the Delphi, that they were incredibly engaged and many of them asked to stay involved with the work that is going on. I think it is helpful to be able to connect with people who are also working in this area. And so our next steps as a Delphi group, and you'll hear more about this from some of the other panelists, is Dr. Ogunwale has started the Mental Health and Justice Network. And we will drop a link to that. It's been a WhatsApp conversation that anyone is welcome to join, that is just people working on this issue, interested in this issue. So we will put a link to that in the chat. We are working on getting the word out there. Part of why we did this Delphi was awareness raising. We want to put prison mental health more on the sort of global agenda and want to try to get the word out there to say this is important and warrants sort of engagement from African governments, from international donor organizations, to say that this is an important issue because that is the type of support, both domestic and global, that would be required to support African researchers and practitioners to begin to address these priorities. And so we will drop a link to the network in the chat, but I want to turn it back over to Charlene to sort of start a conversation. And I think our goal is not that the Delphi is the end of a conversation, but in fact, the start of a conversation about what we can begin to do to take a human rights approach to mental health in these settings.
Thank you so much, Helen, for that comprehensive overview of the study. And I totally agree with you. What was amazing was the enthusiasm of everybody involved who really want to continue this work. So yeah, so I'm eager to jump into questions to our panelists, and I'm going to start with Ade. So you have a lot of experience in the African prison and correctional settings. So in your view, from your experience, so what are the challenges to mental health care? And that can, of course, include policy and legislative angles as well. Over to you, Ade.
Thank you very much, Charlene, and thank you, Helen, for the nice overview you provided to the work. I think that the key problem or challenge for mental health care in African prisons is the commitment of governments to providing equitable health care within prisons. So it seems that those who are in prison are a neglected, forgotten subpopulation. And that does not allow for sustainable development. So if you look at the Sustainable Development Goals, Goal 3 talks about health for all across all ages. And it has two key targets that are very important to mental health. Targets 3.4, 3.5, they talk about mental health disorders and substance use disorders. But that goal also talks about universal health coverage. So if you look at all of this together, you find that if governments were committed to these targets, prisons would not be left out. Now, once prisons are left out, policies will not address prison mental health care. In particular, I know for a certainty that in Nigeria, the mental health policy addresses prison mental health care as well. But it's almost like an add-on. The arrangements are not available. So I go on now to the prison level arrangements. So within the prison system in Nigeria, where I work, you have no practicing psychiatrist as I speak. There may be one or two in training, but there is no practicing psychiatrist for a population of about 80,000 inmates. So what do you have? You have just a number of mental health trained nurses who sometimes are not even available for prison healthcare than administrative capacity. So the healthcare workforce within the prison are basically physical health trained workforce who just deliver the minimal mental health care that they can afford to deliver. Now, apart from workforce, you then talk about the availability of medication. So you find that, like a system in Nigeria, the medication is provided centrally from the Federal Capital Territory Office, the headquarters, the national headquarters. So you are not really looking at the needs of the prisoners on the ground. You're only looking at what you aim to provide for everyone. So if you provide first-generation antipsychotics, for those who need second-generation antipsychotics, they don't get treated. So that's one of the other challenges that were found. And finally, I would say that the prison environment itself sometimes is not enabling, in fact, in most cases, it's not enabling for mental health promotion. So even those who didn't go into prison with mental health problems eventually develop mental health problems while they're in prison. So if we look at all those challenges at these different layers, it can give us a sense of what those challenges might be across different countries. Let me pause for a while.
Thank you so much for that insight, Ade. And it's interesting to really link it to international commitments, like you say, the SDGs. You cannot remove prisons and those in prisons out of that equation. So, yeah, so it always becomes back for me to a human rights issue as well. But let's hear from Sandra. So, Sandra, from your own perspective, what do you think are some of the key challenges for people with mental health needs? What do they face while they're in custody or while they're incarcerated? So over to you, Sandra.
Thanks, Charlene. Just to give a brief background into my experience, I was taken into custody for a short period for a DUI. At the time, however, I was very much in a full-blown mental health crisis. So it was obviously a difficult situation regardless of my mental health, but then obviously further impounded with my mental health situation. I think what Helen has discussed here with priorities is definitely something that resonates with my experience. So there was inadequate screening and assessment upon entry. So everybody is basically treated the same regardless of circumstance. So just the glaring omission of mental health support across the board was quite evident during my stay. She also spoke a little bit about medication, which was also something that I experienced in my little stay. And although I had access to some of my medication, I was not afforded access to some of my other medication, and I was told it was simply unavailable. I did find out that many of the people who were in custody, there was a demand for prescription medication. So an assumption can also be made that it's preventative in a way because people seek it, although they don't need it. But as the situation was, I didn't have access to that. So it made it very difficult for me, obviously impounding with my mental health crisis that I was going through. Safety concerns are again something that was brought up. I had risks of violence and victimization while I was in. I had my life threatened a couple of times by inmates. I don't want to say inmates, people who were in custody rather, to be more comfortable with the language. Yeah, so that obviously made it also quite difficult. I didn't have access to familial support. I was denied a call to my family during the time that I was there, so that also made it difficult for me to connect with people and get the correct or needed support that I had while I was there. Stigma and discrimination is always something that's brought into the mental health conversation, not just in justice systems, but across the board. I think within the justice system, it is even more complex. Because as we know, there is a lot of stigma in terms of people with mental health conditions and how that is assumed to be linked with criminal activity. And I mean, evidence does show it's often the opposite, where people with mental health conditions are actually the victims of crimes and such. So it's a very complex one to navigate within the system as well, not only as staff, but people who obviously are in there. The irony of my stay was that I actually had a conversation with a nutritionist. I had a conversation with legal representation. There was a nun that came from a local church to do a church service. So some kind of, supportive religious care. But the one glaring omission through the entire stay was there was absolutely no kind of mental health support. I recognize that having mental health professionals is quite difficult, especially in an African context, because of lack of resources, etc. But I do think there is space for mental health training, mental health first aid, or some kind of supplemented training for staff that work within the justice system. Yeah, so that's me on that one. Thanks, Charlene.
Thank you so much, Sandra. I love how you refer to it as your stay. Because if I can think, if you're incarcerated, but okay, I've never had that experience of actually going to prison or in that context. I've been to involuntary admissions to psychiatric hospitals, but for me, that experience was pretty much the most traumatic, other than my own condition. And I can assume it was pretty much the same for you. It's like stuck in your head, and that you live with that experience. But thank you so much for sharing. Really appreciate it. Okay, so I'm gonna move on to Dainius. So Dainius, coming from a rights background and having a lot of experience in terms of human rights, how does deprivation of liberty affect mental health and emotional well-being? So in this context, what could be recommended to policymakers? Over to you, Dainius.
Thank you, and thank you again. It's a pleasure to be part of this very meaningful webinar and very timely. Well, globally, we know that there is globally this legacy of closed institutions, not also like prisons, but also institutions which are people are closed for public health reasons, like mental health, tuberculosis, and so on. And also I'm coming from the region of former Soviet Union, which was partly solving the problems by hiding people in institutions, so that to show during Cold War that we don't have these issues, but and that was started from baby homes, because the idea was state may be better parents, so to say. And this is, for me, was sign or symptom of what things go wrong if human rights are taken selective way. Either economic, social rights are neglected, like in neoliberalism, or civil political rights and freedoms, like in some totalitarian systems. So, and it starts from babies, because in baby homes, babies have everything. I mean, they have food, and it is warm, and clothing. So what is wrong? Wrong that they did not have emotional bonding, attachment. They did not have the person who has emotional attachment to them. And this is how this institutional culture starts to damage not only emotional social development, but to damage brain, as it is now shown by modern neurosciences research, that toxic stress, if there is no good emotional relationships between, for example, baby and mother, then the brain will be damaged, and hence we have epidemics of mental health and also non-communicable health issues, because the body will learn to respond in ill way if toxic stress happens in infancy. But when I had opportunity to analyze the global situation, when I had the UN mandate, the painful dilemma was, so to say, maybe it's not correct, I will say, what is worse, to be all this mad or bad dichotomy, which is wrong, because what is worse, to appear in prison or in bad mental institution, so it could be very painful dilemma, because sometimes it looks like prisoners have more rights than people who locked in mental institutions. But anyway, all closed institutions pose risks for physical and mental health for obvious reasons. We cannot guarantee what is necessary, for example, for good emotional well-being and mental health. We know modern principles should be, all settings should be free from all forms of violence, all forms of discrimination, from social injustice, from inequalities. Can we assure that people are free from violence in prisons? Another way, can we assure that the question would be for discussion, can it be such a thing as a good prison? Or can it be such thing as a good large residential mental health care institution? And this is a very important question, because when we discuss in global mental health, happily now it's priority, and all political leaders know that we should invest more in mental health, but then disagreement starts when it comes to how we will invest, yes, how we will, especially this new money, if it comes. Shall we invest in existing infrastructure, which happens in many countries? All these huge institutions are renovated and renovated and renovated. Like in my region, we still have these huge long-term care institutions, which are always improving, which is okay. Of course, the people need better condition, but what about transforming the system? What about abandoning the legacy of closed institution? Of course, prisons probably should stay, especially for severe crimes. But the question is that how to minimize harm. This is about harm reduction. I mean, if we still have these closed institutions, including prisons, but not only prisons, so how we minimize harm which is done by closed environments? Because I don't believe that in closed environment you can always assure dignity and embrace all human rights, because for dignity you need to embrace all human rights and not only one or two of these rights. So this is part of insights that we should advise the policymakers, of course, invest more and more in prevention, like now all this adverse childhood experience and toxic stress. So this is how we can at least reduce numbers of people in penal institutions. But then how can we make these institutions which still exist more humane? And these are all very serious questions. Luckily, we have good practices in all parts of the world. Sadly, these good practices remain more exceptions from the rule, and we still have a lot of places which, when I was traveling in many places in all regions, because the mandate was global, which I maybe it sounds harsh, but I would strongly recommend to close. Like all these, places for youngsters, for youth, which some attempts to address youth violence, but it ends usually that we do this with violence. And then we reinforce the cycle of violence when we want to manage issues related to youth violence. So the places which I have seen for adolescents, for young people, these are usually the places which I would recommend to close, because they simply do not work. But of course, there are also good practice. So maybe I stop for now.
Thank you so much, Dainius. That is quite an interesting discussion about these facilities. I think the gist of the story is also the conditions. For me, it's about a complete overhaul of the system is necessary. And I like what you say, prevention is very important to really correct things in the future. But thank you so much for those insights. I'm going to come back to Ade. Just with a question, what service models may be adopted to address the challenges and to ensure that mental health care access is available within the correctional system? Over to you, Ade.
Thank you very much, Charlene. So if we look at Africa broadly, we realize that we've got one psychiatrist to 1 million citizens. That's the general figure that we cite. In some countries, it's even worse. There are countries that have got only 5 psychiatrists to a few millions of citizens. So within manpower or workforce, within mental health, you've got a small number of people available. Now take that into prison. So out of this small pool, you want to find workers for prison who will deliver specialist care. It just will not happen. So some models have been to do the prison enrich approach, as you might find in countries like the UK. Bear in mind that countries like within the European region of the WHO have roughly 98 psychiatrists to 1 million. 98. So if they have such a model, that might work. But in countries like Nigeria and other parts of Africa, you are not likely to be able to sustainably carry on with even enrich services. I must admit, some psychiatric hospitals in Nigeria have been able to do that, but in the long term, it might be difficult to sustain. So the model that I would be recommending would be to go beyond the enrich, the linkage enhancement model, which is you've got specialists who provide care in prison. We've got to go beyond that, though we can start with that. We then go beyond it and come to the integration model. Now, what the integration model does is that you treat the prison itself as a primary health care setting, and then you train those who are the healthcare personnel already existing within the prison system or the correctional system to provide mental health care. In that way, you are able to shift the task from specialists to non-specialists. And if you look at the pyramid, there is a broader base where you have the non-specialists, and they can be spread around prisons all over the country. For example, in Nigeria, you've got 240 holding facilities across the country. Now, if you wanted to place a psychiatrist in each of the holding facilities, that would not happen because you haven't got 240 psychiatrists to do that. But if you get them together region by region, or what we call geopolitical zone by geopolitical zone, and you provide training, then all those people who go back to their prisons, who are healthcare personnel at different levels, are able to provide the mental health care. We've done something like that in Nigeria by one of the leading psychiatric hospitals in Nigeria for community psychiatric services. So what we did was to train primary healthcare workers within the community to provide mental health care using the MHGAP algorithms. So they're able to look after people with psychosis, with depression, with anxiety, other significant emotional complaints, epilepsy, and substance use disorders. So you must then, when you've trained them, identify, or before training, you must identify priority conditions based on prevalence estimates. And this is where the point that Helen was making about prevalence studies comes in handy. From the prevalence studies all over the world, we know that the key conditions are depression and anxiety, psychosis, substance use disorders, mainly. And then we've got people who are trained to be able to intervene in those. That is likely to work better. But for now, if what we've got is the linkage enhancement model or the specialist services going into prison, by all means, let us make the most of that. Now, having said that, training will not stand alone. Funding for mental health care in prison has got to be bespoke. If you don't make it bespoke and you bury funding for mental health care in general health care, I'm sure that Dainius can say this, that mental health care is neglected when you have a pool of funds. So only a small bit of the fund will go into mental health care. So bespoke funding for mental health care will be important. And finally, it's important that in understanding the equivalence of care, the level of care in prison should be similar to the level of care that is provided in the community. If we have such a goal or target, then we would also be able to deal with the human rights considerations that come with care in incarcerated settings. I'll leave it at that.
Thank you so much, Ade. Yes, equal care, no matter where you are, community or prison, which is important. I like I can completely understand the context differences to have this task shifting or sharing model approach that would work best in the African context. Thanks so much for sharing your expertise in that area. So looking forward to hear from Sandra about, Sandra, your observations and experiences of how people in custody were supported or struggled to be supported by one another, and how did prison conditions impact their basic rights and as well as their dignity? Over to you, Sandra.
Thanks, Charlene. I'll speak to the support elements of that. So it's almost like an umbrella field of peer support for people who have been in custody for an extended amount of time. So it's almost like a naturalized kind of peer support structure that happens, especially in custody settings. Some people have been in custody for over 7 years or up to 7 years awaiting trial. And I think that speaks to a larger problem within the justice system. So like I said, there's a trust that's built within the system, within the people that have been, put in there, or inmates. And for many, this has become a home. If you're in a place for up to 7 years, it's all you know, and it's seldom you get out. You're within the walls of the cells. Very little outside integration, if I can put it that way. And within that, there's also specific rules and structures that one would find in our home. So it was very interesting to note that kind of thing. There's specific rules as to how you make your bed, how you clean the cells, because there's no assistance from the staff. That's all done by inmates, etc. So for me, what was very interesting is I sort of a microcosm of society in many ways, because there's different economic situations and social situations within the system. But also within that, there were also acts of kindness and solidarity. And I think, especially because I was, in a mental health crisis, there was that's elements of vulnerability. And within that, there was a sense of empathy and compassion from other people who were in the system with me. They were sharing of food, I'm a smoker, cigarettes are very important to me, or were, sharing of hygiene products. So there was still that element of support from some in the system. I think in terms of, I'm going to come and kind of roll back to the peer support element, a very informal kind of peer support system. Obviously, it's not formalized in any kind of a way, but there was a lot of sharing of personal experiences. And for me, that created a bit of a safe haven for me in that space. But because beyond the circumstances of being there, I was there, and there's some kind of a community feel that was kind of generated in that space. And I think it just indicates the importance of storytelling and peer support, especially in times of turmoil. And although I was in a difficult mental health space, that's not only for me in a difficult mental health space. People are incarcerated or in custody. It is difficult as is. So yeah, like I said, the informal nature of peer support was quite nice to see within the system. When we speak about challenges, there's obviously some glaring challenges as well. There's violations of basic human rights. Something like, as I mentioned before, there's absolutely no access to mental health support in any way. Overcrowding is something I think we all know happens, especially again within I'm going to speak from an African context. There were 2 to 3 people that shared a single mattress at a time, so it was incredibly overcrowded within the cells. Access to basic toiletries, such as toilet paper, were very difficult. Often other inmates had visitors, and that's the way that they would get the basic needs, such as toiletries and such. And there's also obviously dehumanizing treatment in many ways. The frequent disregard of individual needs, because everybody's kind of clustered into the same label of you're a criminal, and it's not the case. There's no deferring of conditions or circumstances. And then obviously another big one is a lack of privacy and dignity. I mean, there's no space to be on your own, to seek your own comfort, to self-soothe. So, you obviously have to manage all these things. Yeah, that's me on that one. Thanks.
Thanks so much, Sandra. That was actually an important point that I appreciate that you brought up. Following on what Ade spoke about the lack of human resources or mental health resources within prisons, is how valuable peer support could play in aiding the mental health care. And I think what you described is actually just an example of this could work if there was peer support, and maybe even in a more formalized structure could also be considered if we look at developing policies in this field. But thank you so much. I really appreciate you sharing your experiences. I'm going to move on back to Dainius. So, Dainius, are there differences? I think we heard that there are differences in regions and context in the field of mental health and human rights. So, how could this be taken into account when we develop mental health policies and services? Over to you, Dainius.
Okay, thank you. Yes, so again, from my experience when I had the mandate, the UN mandate, initially I had this narrow experience mainly of my region or sub-region, and I idealized the advanced developed countries, and when we reach this level of mental health services, like in, for example, Nordic countries of Europe or, Canada, and so on. And then because mandate was global, I had to see all continents to look for what is common challenges. And now it's no secret that the discussion in global mental health is again the very question where this reform, which is already recommended by WHO, yes, to move away from legacy of coercive services and over medicalization, where it is easier to do, and many experts will tell in global south, because there is no so much resistance from very powerful lobby of my profession of psychiatry, which have I should say almost monopoly of power, and it happened so because of biomedical models. So only doctors know, but doctors do not know what is what is schizophrenia about, in fact, and even chemical imbalances in the brain appear to be only hypothesis, which was never proven. So in this context, it's a very creative situation when a global south may have more space for innovative, creative, culturally appropriate, non-coercive services. Of course, we need space for civil society for that, so we need democracy. But if we have it, and it's happening already, because in WHO documents we see good practices such as friendship benches. Yes, so could it happen in Europe? I'm not sure. So this is one paradox or one interesting development, which comes from the idea that for this new search of new paradigm, after many clouds are gathering over biomedical paradigm because it was excessively used. It's not wrong, but when it is excessively used, it goes wrong. So all countries, including developed countries, rich countries, high-income countries, all countries are developing countries. So there's a very good competition because all countries start from rethinking, and then it's a problem of how to cooperate, how to minimize, how to address. I think those will be more effective, which will overcome this burden of challenges, which are overuse of biomedical intervention, power asymmetries, yes, because of paternalistic, attitudes, users of services have been disempowered. The promise was to empower with the biomedical model, but in fact it was disempowered because of huge power asymmetries between professionals, especially those who have medical background, and users of service. So if we manage those countries who manage to overcome this asymmetry of powers plus biased use of knowledge and evidence, then it's a lot of good It's interesting that the Human Rights Council in Geneva, which can be not very human rights friendly on other issues, is leading is leading. If when we read the resolutions, there were 4 resolutions of global on mental health and human rights, and they are revolutionary. Yes, they tell all these right things, and then finally WHO had these 3 guidances, yes, in 21, 23, and just now in March in this year, and all these guidances call for urge all member states to actually to change the paradigm, which we know is very difficult. But again, I see most resistance in Europe. In one more paradox, the most largest numbers of let's say again closed institutions are still in Europe, in European region. So the more money, the more ineffective investments. So we have to overcome this, and Europe is not a good example. So the headache for all experts is what we now should recommend for developing countries, like, for example, African continent, if we don't recommend the pathway which developed countries have gone through last 40 years with, I should say, overuse of this idea that we should find everyone with, we should diagnose everyone with even mild condition and then take some individual either medications or psychotherapy, and now it's more, I think, about social determinants of mental health. So this would be my comment.
Thank you so much, Dainius. I like that you spoke quite a bit about power imbalances and the paternalism. I think for us, since we started the organization in 2018, I mean, it's quite great to see the shift, even from 7-8 years ago, how people with lived experience, although it's not perfect yet, but there's been quite a large shift. And even if you look in this Delphi study, I mean, even for us to be part of such a discussion would not have happened like 20 years or odd ago. So, but I think it's good to kind of amplify and emphasize the value of lived experience, and also to be involved in the policy development and upscaling like services within prison systems, and kind of to overhaul the system to really protect mental health and well-being. Okay, I see I want to leave some time for Q&A, questions and answers. So I'm going to jump right into questions. If anybody or any participants from the audience have any questions, you can either put it in the chat or you can raise your hand, and we can, Zach, just help me to do that. And Helen, if you can help me just to fill these questions so we can have a Q&A session for about 10 minutes.
I just want to know, Charlene, there is the Q&A block.
Okay.
There are questions in there as well.
Yeah, I'm happy to read a few of those off. So the first question is for Sandra. What would you say is the most urgent thing that needs to be done to support persons with mental illness who clash with the criminal justice system, besides making mental health care available? So outside of this, I think, as Dainius says, clinical service provision, we perhaps rely overly heavily on that model when we can be thinking more about these social determinants and other things that need to be put in place. So I'm curious if you can comment on that a little bit.
So I think it's important to educate police services, security companies. It's the first point of contact, obviously within criminal justice systems. And often all they know to do or are taught to do is, obviously, if it's deemed a crime, it then obviously falls within the justice system. So it's important to have some form of mental health training for first responders, if I can put it that way. In a South African context, and in my experience, it hasn't been great. And I think there is definitely scope there. However, I'm also very aware that, it's low resources, and it's often a case of more responsibility. So I'm also cognizant of the fact that, first responders or police services, their mental health and their well-being is often overlooked. So before we look at helping others, it's an element of, how are we helping them and ensuring their well-being, and that they have the emotional and psychological capacity to deal with these things, because there's no debriefs. It's kind of just the job. And I think also statistics show the amount of PTSD that a lot of these people suffer because of, the impact of that. So like I say, it's from the get-go. What happens, the immediate situations, how is it dealt with? If there's not capacity from first responders, who's there to support? Is it possible to have additional resources, especially when it's a mental health kind of situation?
I can ask the next question, this one for Dainius and Ade. Ade, maybe you can start. What impact will the guidelines on deinstitutionalization from the United Nations have on psychiatric institutions, in your view?
Well, thank you very much, Helen. In my view, I think that deinstitutionalization is something that we have seen before. So it was a movement in the 1950s up till the 1980s in Europe. And you were looking at closing down big institutions and then allowing people to be treated. How? So what happened was the Penrose Law, in which the hospitals were being closed down, the population in the hospitals were reducing, and the populations in prisons were increasing. That was called the Penrose Law. And we don't want that to happen again. So I go back to where Dainius ended, social determinants of health. You must ensure that those social determinants are in place. You must ensure that community mental health is strengthened. You must ensure that referral systems are efficient. And you must ensure that you integrate mental health care into all services under the ambit of universal health coverage before you make another move at this institutionalization. If we were to go ahead without all those things in place, we will be back to Penrose Law all over again. Thank you.
Can I add? I think we have a really good guidances from international organizations, United Nations, World Health Organization, also on the institutionalization. What happens in many countries that on the level of formulation of policies, again, usually it's quite good. Something happens with implementation. It's some diversion happens. And there are many examples. I know many examples when even with, like in many of my region countries, those who joined EU during last 10, 20 years, the huge EU funds were used to renovate these institutions instead of transform. Yes, I know sad examples, including from South Africa, what may happen if the institutionalization is well not well managed. So this is mainly, first should be political will that we move in this direction, and then should be professional, competent management, of course, and funding, because all this change needs funding. So we have good examples, but again, it depends on political will and sustainability of all this process. In my region, my country, with children, we managed quite well because we had a lot of children, including small children institutions, and this is happening. The change is happening. With adults who have psychosocial disabilities, we have the same number of people living in large institutions, but they, as I told, they are better physical conditions, but still they're locked. Interestingly, the new cases are coming from psychiatric system, because the psychiatric system has mainly medications, which is needed, psychotropic medications, but does not have real community-based psychosocial rehabilitation. So usually many people with more serious psychosocial disabilities, they end up in these long-term care institutions, despite that EU funds were supposed to be used for transformation, for changing of infrastructure, but so far this not happened. And when we have very renovated institution, you cannot close it because a lot of money was used, so it's like holy thing, and I think that this is example how system can be very creative in resisting changes. Okay.
Thank you so much, Dainius. It's quite interesting to see. I like when you also said, like, when you close institutions, I mean, history showed that then they end up in prisons. Yeah, it's quite interesting. Good discussion going there. I don't know, Helen, if there's any more text Q&As. There is Kelly. I'm not sure if she had a hand up for quite some time. I don't know if Kelly have a question. I don't know how to do it, but allow you to speak, unmute, and then you can ask your question.
Charlene, I have unmuted her. I just want to see.
Oh, there we go.
There we go.
Thank you, Clarence. Kelly? It doesn't seem like Kelly is
Charlene?
there. Yes, Ade.
Yeah, there's a question from Tom Stevenson. I just saw it in the question and answer box. Okay.
Oh,
Good.
great. I can
Okay,
read that
Helen.
one.
Okay, great.
So this is from Tom Stevenson. He is asking, my question is about which government ministry is typically responsible for prisoners' health in an African context, and what role, if any, this has for promoting equivalence. In the European context, WHO recommended for this to be under the Ministry of Health instead of the Ministry of Justice, and this has been implemented in some countries in this region. And I know that this is certainly has been an issue of discussion in Zimbabwe as well. So would turn it over, perhaps, Ade, you can start with that question.
Yeah, thank you very much, Helen, and for Tom for asking the question. Right now, I'm working on a paper looking at that aspect as well. It's just one small part of the paper. Now, the idea is that in countries like Nigeria, to be precise, the healthcare of prisoners is under the Ministry of Interior. Now, the Ministry of Interior looks after prisoners. So the correction system is under the Ministry of Interior. In that case, the funding for their healthcare is buried within the Ministry of Interior. So there will be a prioritization of needs, and certainly mental health care falls to the bottom of the pile. So in my view, I think that the healthcare of prisoners should be partially, if not entirely, devolved to the Ministry of Health. However, countries that are federating countries in which you've got state governments who have some degree of autonomy, the conversation becomes more complex because each prison is sited in a state, but the oversight of the prison is resident within the federal government. So there will now be multi-layered conversation between the Ministry of Interior and the Federal Ministry of Health, as well as the State Ministry of Health. It gets more complex. Where there is no sufficient funding, in some cases, we have managed to drag the Ministry of Justice into the equation to provide funding because they have jurisprudential interest in the patient. So it's more complex if you do not devolve to health. They must devolve the healthcare of prisoners to the Ministry of Health, if not completely, partially. For example, in the Nigerian guideline for mental health care in prisons, it is said that where you've got no psychiatrist in the prison, the doctors with the State Ministry of Health are expected to step in and look after the patient or the prisoner. The problem is the doctors under the State Ministry of Health are not employees of the ministry overseeing corrections. So they do not have any duty as such to deliver that healthcare. So they will deliver it not out of statutory duty, but out of convenience, meaning that that healthcare will not be equivalent. So it's important that if part of the healthcare budget in health is for prisoners, then we can always tap into that, if not the whole of the evolution of prison healthcare to the Ministry of Health. I don't know what Dainius will feel about it, but that's my own proposal. Yeah.
Thank you so much, Ada. And once your research is done, just to share it with us, it would be quite interesting to see. We're getting close to the end. I think if there's more questions, if panelists can type those. Just before we close, I just want to go back to Helen. You were an integral part of this entire project, so I still just want to hear from you. What interests you in this field of prison mental health or mental health of incarcerated persons? And just to say, what do you see for the future in the space to happen, going forward? How can you see a system that's ideal? Over to you.
Thank you so much, Charlene. I think as a physician and researcher who's really focused on mental health and substance use, it's hard to not find intersections with incarceration in much of the work that I do. And living in the US, which has one of the highest incarceration rates per capita in the world, I frequently see intersections between my patients and the carceral system, and actually provide some clinical care within the carceral system. And I think that sparks my interest in this work, because when we think about groups of people who most need mental health care, substance use treatment, protection of basic rights, it really is people who are incarcerated, who are often neglected and forgotten, and need this attention and this advocacy and this research and this funding brought to bear on what they are experiencing. And I think as we look forward in this space, I would hope to see more focus on both creating alternatives to incarceration for people with mental health conditions and substance use, right? What does it look like to have diversion programs, to have ways to allow people to get treatment rather than go to prison, but also recognizing that in much of sub-Saharan Africa, that community-based treatment is also not necessarily readily available. So what does it take to adapt a diversion model for those settings? But also recognizing that people will remain in prison, and that we need to be able to start with the basic infrastructure. We need to be able to have enough space and enough food and enough, meeting those basic social determinants are a prerequisite for beginning to address healthcare conditions. And so I think this is a problem we cannot over-medicalize, but need to really be thinking about meeting basic needs in conjunction with delivering mental health services. And I would like to see this be more prominent on the global mental health agenda, not only the research agenda, but I think more importantly, the practice and implementation agenda, that I would like to see this more part of not just global guidelines on prison, but really global guidelines on mental health. That when we think about mental health, we also need to think about the unique needs of people who are incarcerated. And so I hope that we as a community can work to continue to raise awareness about this issue and try to make health and mental health during incarceration part of this broader conversation. So I really appreciate everyone being here and everyone who's participated in the Delphi, because I have learned so much from all of you.
Thank you so much, Helen. And I just want to thank each one of you for really sharing your expertise, your views, and also your passion towards really protecting mental health and well-being of everyone and people's human rights, kind of to really drive that forward. And also, thank you, Helen, Ade, for involving the peer network in this project. It was really exciting. It was something different. You don't always hear about mental health of people, incarcerated persons, being discussed in global platforms. So it's really nice to see this being brought forward. Thank you so much, Dainius, with your expertise in the human rights front. And also Sandra, bringing your lived experience also gives a really positive and very powerful view of what we need to look forward to. Thank you so much, and thank you for everyone who joined. We are going to upload the video as well to our social media channels. So keep an eye on that so you can share it with your friends or colleagues who could not make it. Thank you very much. All the best.
Bye-bye.